right, good morning. Welcome to Stanford Children's Grand Rounds. We are very happy to have all of you here with us this morning. As usual, to get your CME credit, please do text 34395 to the number on the screen so that we can record your presence. And again, welcome. We're excited to have all of you here today. Just a few announcements about upcoming Grand Rounds. On May 22nd, we're going to hear about perinatal care in the era of COVID from Doctors Aziz, Davis, Lee, and Prophet. So join us for that. And next week, a very special lecture, the Rudine DiCarlo Memorial Lectureship. And we'll be hearing from Dr. Lucy Kalananthi, and her talk will be a fireside chat about When Breath Becomes Air, Finding Meaning in Compassion in Medicine. And it's a beautiful book if you haven't had a chance to read it, a short read, and can really recommend it. So looking forward to that next week. Today, we are excited to hear from our own Dr. Bonnie Maldonado as she gives us the Red Book vaccine update. And Bonnie really needs no introduction to this audience. She is doing so much work for all of us, and on behalf of all of us, thank you, Bonnie, for all your work with COVID. And today she's going to share with us about vaccine updates. So please do enter your questions, and we will be moderating those at the end. So turn it over to Bonnie.
Great, thank you. Well, good morning, everybody. And I'm going to try not to talk about COVID today, so there might be a few slides at the end if just for some brief updates, but I wanted to talk about the Red Book. You know, we're still working on the Red Book right now, and wanted to share that with you. I can get my slides to start moving here. There we go. So all of you know that we have a Red Book committee. It's called the Committee on Infectious Diseases, and I've been the chair for the last 2 years. I've been on the committee for since 2010, so it's been a while. It's been a really exciting opportunity to work with a lot of great infectious disease people around the country. We are planning on publishing the Red Book, albeit in an unusual way because of COVID. Of course, the American Academy of Pediatrics, like other organizations, has shut down their operations to a skeleton crew. And so instead of having our usual meeting, which would have been last month, actually, to put the Red Book together, our editor, David Kimberlin, is actually curating all of the edits that we've put together over the last 3 years. And we'll be doing an abbreviated meeting in June so that the Red Book will still come out on time, so some things still happen. We'll have our Red Book probably next spring, 2021. We will have some real little COVID surprises in the book for all of you to see. So today I wanted to talk a little bit about some of the work that we've been doing on the Red Book Committee, just a couple of topics really. The committee, as you probably know, is made up of pediatric infectious disease doctors from around academic medical centers around the country. It's 15 members with 15 plus liaisons now from NIH, CDC, FDA, international pediatric societies, and others. And so it's a really great group of content experts. And we did have our meeting a month ago virtually. And that was, again, very informative, but really focused on some key topics, which I will try to address today. So I am a member of a data safety monitoring board for a Pfizer vaccine trial. And today I'm going to talk about just very briefly about the vaccine schedule. Not much to say there because not many major changes, but I'll incorporate those into the talk around the seasonal flu, which I'll go over. And I'm actually going to talk a little bit about some potential parallels with pandemic flu in 2008 and what happened after that regarding the next season. Talk about the impact of RSV on infants who are not receiving palivizumab, and this is just a review report that we'll be sending out in the next few months to update everybody on a follow-up from our policy to restrict the use of palivizumab. And then if we have time, I'll talk a little bit about a few updates on COVID-19, but not too much time on that. So as you can imagine, the schedule changes all the time, the Red Book schedule, the vaccine schedule for children. But one of the things that we tended to do in the last couple of years now is we have not made any major changes to the routine schedule. So we only have one schedule, that's the ACIP schedule, that's the federal schedule from the CDC. And we don't want to confuse scheduling. So we actually just try to harmonize as much as we can with the CDC. And when we don't, for example, if there's some minor deviations or differences in age range, the CDC has kindly agreed to add those to the bottom of their footnotes. So you'll see sometimes, for example, with hepatitis B vaccine, HBV vaccine, they will say AAP recommends this interval as opposed to the one we recommend, et cetera. So that we all have one vaccine schedule that we can all use. And so there's the link to the vaccine schedule that you can download and use, and should be available now. I wanted to start with the flu, and this is a slide looking at the burden of disease overall. This is just since 2010, a compilation of cases, hospitalizations, and deaths. So the annual burden of the flu can vary substantially, but it's still quite a large burden. And if you think about the flu within the context of we're experiencing today, I would say that it's comparable, if not exceeds it. I think what has happened in many cases is that we've gotten used to having our annual pandemic, because this is an annual pandemic, and everyone thinks about this as, oh, well, it's just the flu. But it does cause substantial death and disability as well. And there is a vaccine for this virus, so we need to remember that. Now this year, the CDC has some early estimates. Now we won't know the full extent of the flu impact until the summertime, when they can go back and review all of the data. But at least from this point through a month ago, it's estimated that between 40 and 55,000 flu illnesses occur, million flu illnesses occurred, with about 18 million to 26,000 visits, 410 to 740,000 hospitalizations, and between 24 and 62,000 flu deaths. Now this is in the US, so you can see that this is a pandemic that still makes a big dent in our population. It's very important medically. I think we have tended to learn how to, unfortunately, live with the flu, but we also need to think about vaccinations, and I'll show you our vaccination coverage in a bit. Now, if you look at the positive tests that we've had so far this year, you can see that we had a really unusual year for a number of reasons. One major one, and that is that if you see there in the green, those are positive tests reported to the CDC by the surveillance labs that do this. You can see that the vast majority of the early cases were B cases, influenza B. And then we saw a later wave of influenza A that came in early 2020, and that's very unusual. As far as I can recall, I've never seen a season where we've started off with the B virus and then ended with the A. Now, I don't know what the clinical significance there is, but it is definitely a major shift in the circulation. Usually the flu A viruses circulate first. So it was a different year in that respect. And here I'm showing you the influenza epidemiology. And the top here is 2018 to 2019, 2019 to 2020. I'm sorry, 2017 to 2018, 2018 to 2019, and then here's this year. And you can see 2 years ago, we really had an H3N2 year. Sorry, the wording is still even smaller. Yeah, H3N2 primarily. And then we had a small B year, but the denominator was quite high here, much higher than last year, where we had up to 5,000 positive samples at peak here. on a given week, and here they were lower. And we did have H3N2 delayed, but H1N1 started the season last year. And as you see here, this year we started to see predominantly early B disease, and then followed by a late onset A peak. And then these numbers are comparable to those that we saw 2 years ago. So a little bit, again, just, just this reflects just the different shifts in the virus that's circulating, and the reason that we have multiple strains in the flu vaccine, because you're never really going to know which virus will be circulating from one year to the next and when it circulates. Now this slide shows you influenza outpatient visits and hospitalizations for this year as well, and it's superimposed on what's happened in the past. So this red line is this year, and you can see we had a number of spikes, and it's likely, and the CDC says the same, that this W shape here may reflect COVID. As you know, COVID came into the US right around here. So you saw that we started seeing a drop, and then maybe because people were coming in more often, we just started to see a peak again of influenza-like illness. This is not just the flu, but everything that came in. What's interesting to note here in this slide, and I'll go into it a little bit more later, this was the 2009 pandemic. So you see that early in the year, the pandemic started in April, end of April, early May, and then it really peaked out late in the year, and then it dropped off. And then that next fall, we saw very little disease in that year. So the pandemic year was followed by a very quiet year. And then in 2011, right after that, again, you see for a couple of years, we saw very mild disease. And it wasn't for another couple of years that we started to see increases. So by 2014 here, you saw a peak, and then 2015. So this, now again, coronavirus and flu are very different viruses, but it turns out that with the big peak in pandemic disease that first year was followed by quieter years for a couple of years there. So I don't know what that means in terms of what might happen the coming year with flu or RSV or even COVID, but it'll be interesting to try to model, see if people can model that epidemic. Now, if you look here at lab confirmed hospitalizations, this is the pandemic year here. So you see that we saw a peak in hospitalizations early in 2009 because that's, as I said, that year started late, very, very late. It started in April. And you can see that we had a very low rate of hospitalizations the year afterwards, but then it started to go back up. And now you see 2017, 2018 was pretty high, and 2019, 2020 so far has been reasonably high, but not as high as last year. So we're starting to see another increase in cases, and that reflects circulation. And even though we have herd immunity, circulation of viruses that have mutated over time, particularly H3N2, which last year saw significant mutations away from the vaccine strain. Now, this is pneumonia and influenza mortality from the National Center for Health Statistics. And you see, this is data through the end of April. And you can see that relative to most recent years that we had a real peak in pneumonia and influenza mortality. And a lot of this, of course, may reflect COVID because this is not just flu. You can see here that our pediatric deaths associated with influenza were very high this year as well, somewhere along the lines of what we saw in 2017, 2018. So it was unfortunately a high year for pediatric deaths at around 170 confirmed so far. Now, I wanted to go back to 2009. I had a really hard time finding slides or data from the CDC website. So I went back and looked at my own slides from the H1N1 pandemic in 2009. And this was a slide that I found of positive tests that were reported to the CDC from 2008 to 2009. And you could see here that, remember, the year 2008 would be here, and then this is 2009. And remember, we saw the pandemic strain pop up here in April. So you can see here that these are the old strains. This is B, this is the old A strains. And then this is the new pandemic strain that showed up in 2009. You can see how it peaked out in April, but it tailed off somewhere along October. And that's when the vaccine was available, so if you recall. So we saw a bimodal peak there with the new strain popping up several months after the regular circulating strains. And then if you look at this in more depth, this is 2006, 2007, 2008. Here's the pandemic that happened and flu, and then you saw a very low year following that. So again, I'm trying to not over interpret this, but the question that people ask is, are we going to see a bad flu year? Are we going to see a bad COVID fall? And it's hard to know, but just based on this data, there were substantial numbers of people who developed immunity. So we certainly, as I've mentioned, don't have enough herd immunity to keep us from getting COVID, but whether or not we see a slow respiratory season this year, especially with respect to flu, will remain to be seen. But that's certainly what we saw in 2009 to 2010. And then this final slide looking back is what we saw back from 2002 to 2012. I wanted to look back again. I pulled these out from my old slides. So what you saw here in 2002 in the yellow was a low, what they call a moderate season. And then in 2003, you saw a high level season. And then 2007, another high late season. And then the pandemic year came along here and really peaked out, but then tailed off. And then it took a couple of years of low seasons, but then you started to see another peak about 2 years later. So the point being that at least after the pandemic flu, there's a lot of evidence that that following year, or that would correspond to this coming fall, it looked like the season was a lot slower in cases than the year of the pandemic. So we'll see to what extent this happens this year, and whether or not coronavirus plays a role in that. Now, when we go forward and look at our underlying conditions or comorbidities, it's as usual, the vast majority of adults here in the blue had comorbidities. And so you see no known conditions, so no underlying conditions. Only 8% of adults had no underlying conditions who were hospitalized for the flu. Whereas for children, that number was well on the order of 50%. So this is why it's so important. It's always important, but it's especially important to think about that in children, because most of our kids who get hospitalized don't have underlying conditions. And then I wanted to show you some data around flu vaccine effectiveness. And you can see here that overall this year, for influenza A and B, our flu vaccine effectiveness was about 45% overall. And in children between 6 months and 17 years of age, the vaccine effectiveness was much higher at 55%. So that was a good sign of the year. This year, the vaccine strains seemed to match pretty well with the circulating strains of virus. And then if you look back to last year, it's very similar. We saw the very similar things last year, that the overall rate was 47%, but in children it was about 61%. So we, again, think that that's probably a good sign. Now, the only issue that we have this year, so far we don't have any good updates yet on a lot of granularity on around H1N1. And you'll see here that, oh, let's see if I have it, sorry. Let me go back. So if you have here overall H1N1, it's about 37%. And for the B vaccines, it was very good as well. As I told you, the B vaccines predominated this year. And by the way, we won't have data for some time to come on the impact of type of vaccine. So we don't have any data this year for LAIV versus IIV, inactivated vaccine, because there was a shortage of LAIV. So we may not be able to get that data for some time to come. This is another slide that I want. It's somewhat encouraging, but we still need work to do. And this is influenza vaccine coverage in children 6 months to 17 years of age in the US. And you can see that from 2010 forward, we seem to be doing a better job. We had a slight dip last year, but years ago. But last year we had about 3/4 of our children were being vaccinated at the high end, but an average of about 63%. And this data was actually being collected in part because we were worried that with the switchover back and forth from LAIV to no LAIV back to LAIV, and then now LAIV being in short supply, were we going to see reductions? And what we're seeing is that we have a slow but steady increase over time. So we don't think that LAIV reductions had an impact at all on flu vaccination, but it's also encouraging that we're seeing an upward trend in children. And I just wanted to show you this slide looking at, this is a little older slide from 2018, but looking at overall flu vaccine effectiveness. And we know that vaccine effectiveness is somewhat of well, it's definitely a guesstimate, an educated guess as to what strains are gonna be useful for the coming season. You see over time, based on the CDC's flu vaccine effectiveness surveillance network, they measure outpatient visits for PCR confirmed influenza infections, and they compare the odds of vaccination among outpatients with acute respiratory illness who either have or have had PCR confirmed flu with and without PCR confirmed flu. And you can see here that the flu vaccine effectiveness over the years have ranged from a low of 10% to as high as 60% here in 2010. That was actually, remember, the year after the pandemic. So we had a very good match that year. And so the numbers range, but you could see here it was 36%. And as you saw, the final estimates were actually around 47%. And now we're up at 50%. So we're doing a reasonably good job. You know, we like to say glass half empty. Is the glass half empty or the glass half full? And I like to think that it's just the size of the glass more than anything else. So if you're seeing hundreds and hundreds of hospitalization deaths and thousands to millions of cases, then even if you reduce half of those, that's still a really important milestone to reach. So we think that flu vaccine is obviously still important. And I think pediatricians always lead the way in that area. So I just wanted to let you know that for these are not adopted yet. The proposed vaccine for this year, flu vaccine, will be voted on in June. So we have this ACIP will be voting on that in June, and the AAP has already put their statement together in anticipation of that, but it hasn't been voted on by the board of the American Academy of Pediatrics. So these are not official data. But the recommended influenza components, I can't give them to you. They're not approved yet, but, or at least they haven't been voted on. They will be changed for all of the 2A vaccines, the H1N1 and the H3N2, as well as the B Victoria, but the B Yamagata vaccine component will be unchanged. This year, all pediatric vaccines will be quadrivalent, so there won't be any more trivalent vaccines. As I said, you saw there that we're having, we have circulation of all 4 strains. So all of our pediatric vaccines are now quadrivalent. And the dosing is all children 6 months to 8 years of age who are receiving influenza vaccine for the first time, or who have only received 1 dose in the past prior to July of this year, should receive 2 doses of flu vaccine, ideally by the end of October. And the vaccines should be offered as soon as possible. And I'm not going to go into detail right now about this, but there are some data in adults only, and very preliminary data that suggests that in adults, if they get their vaccine early in the year, that is in September or October, that there may be some lack of protection of those adults for late seasonal flu. So for example, they are protected in early, in the winter, but by the time you get back infections in March or April, it appears that adults, anyway, a subset of adults may actually have more breakthrough disease by that period of time if they've been vaccinated early. There are no data in children to suggest that yet, and certainly there is no recommendation to vaccinate people twice, or to definitely not to delay vaccination. So some people, we've been seeing questions on the internet and to us at the Academy and others about whether we should be delaying vaccination to get the boost, an opportunity to boost your titers for the potential late season, that is a season that extends through March or April or beyond. And at this point, there is not enough data. CDC have not recommended that, and we are not recommending that. But if you hear that, it is coming up, and we are looking at trying to pull data together about that information, about that phenomenon, and whether or not we should be changing our recommendations is not clear at this point. Certainly, you'd have to really make a calculated guess as to whether you think it'll be an early or a late season, and we never really know what's going to happen. Or think about vaccinating 2 doses a year, and certainly we don't have the capacity to think about that yet. So at this point, we have not seen this data hold out for children. It doesn't seem to be at this point an issue for kids, but we'll keep you updated on that. Other issues, these are small points, but I think it's important for everybody to know that the vaccine formulations now are all updated and a little bit cleaner than they have been, but I just wanted to give you a little flag, a little alert that the Afluria quadrivalent will be the only vaccine with a dosing volume of 0.25 mLs for children between 6 months and 35 months of age. And that's because the Fluzone quadrivalent was previously available at the 0.25 ml and 0.5 ml presentation, and now will only be available in the 0.5 ml presentation for this age group. And then the other 2 vaccines available for this age group, Fluarix and Flulival, will also be at 0.5. And just wanted you to be aware that there will be a 0.25 formulation available for Afluria, so be careful with dosing of children. Make sure you're not giving them children, you're giving the right dose of the vaccine, because there could be, make sure you know what product you have in your office and that you're giving the proper dose. Again, the AAP at this point has no preference for one product over another. The contraindications for LAIV have been updated to harmonize with ACIP. We did a pretty thorough literature review, and why we don't see that there are any reports of additional safety risks for LAIV, the ACIP continues to recommend that children with, that there are contraindications for children with immunodeficiency, anatomic or functional asplenia, cochlear implants, and active CSF leaks, because it is a live attenuated product. So when we looked at this, there are no reports of safety risks in these children, but we did want to harmonize with ACIP on that. And so I'll stop there around the flu, and we should have time for questions at the end, I hope. I wanted to just go over RSV and palivizumab, because I know that hasn't been an issue recently, but it has been an issue in the past. And also we're going to come out with a technical report, hopefully sometime this year, updating everybody on what we've seen with our policy around RSV and palivizumab in the premature infant. So just by way of background, we have provided, the American Academy of Pediatrics has provided guidance around palivizumab since it was first licensed, and the first policy statement on palivizumab and RSV came out in 1998. And that guidance has been updated a number of times over those years to reflect the most recent literature regarding children at greatest risk of severe RSV disease. And the last update in 2014 drew quite a bit of controversy because we refined our prophylaxis guidance to focus on children at greatest risk. And so because that was 6 years ago now, the board has asked us to just go back and review the data regarding seasonality of RSV circulation, incidence and risk factors associated with bronchiolitis, and the potential effects of the implementation of our prophylaxis recommendations on hospitalization rates and mortality of children with RSV. So the question was to us, should we change our RSV palivizumab guidelines? And I'll tell you what those are in a bit. And so we actually did a literature review over the last couple of years. It's been a 2-year process by the Committee on Infectious Disease, and we supported the reaffirmation of our guidance, and I'll go over that, among infants and children at increased risk. And our review of those publications did not support a change in recommendation. The board of the American Academy of Pediatrics affirmed that, and so did all of our liaison members, the American Academy of Family Practice, et cetera. So we will be publishing a technical report. We've reaffirmed our 2014 guidelines, and we're publishing a technical report this year. So let me talk about what we recommended and why. So when we looked at the guidance starting in 2012 to 2014, we looked at the almost 4 million births in the US in 2012, of whom preterm infants represented 11.6% of all births. This is preterm of, we define that as less than 37 weeks gestation. And infants less than 28 weeks gestation accounted for about 0.7% of the annual birth cohort. So a very small percentage of the population of births. And that infants born between 32 and 35 weeks, so that is the other higher, older group of premature infants, represented about 9% of the birth cohort. So a substantially larger proportion of the birth cohort. And beginning with the first AAP statement in 1998, the high cost of palivizumab, from very early on, people were worried about the cost of prophylaxing children. The original recommendations really included children as old as 35 weeks gestation. So it was really a large, not only a large percentage of the birth cohort, but it was also a fairly large cost to the healthcare system. And so the idea over the years has been to really understand who is really at highest risk for mortality and hospitalization from RSV in this population. Remembering that these overall represent about 12% of all of the births in the United States. So at that time, the CDC new vaccine surveillance network, which is a 5-year prospective population-based surveillance program, really was focused on looking at surveillance on hospitalized, laboratory-confirmed RSV hospitalizations for the seasons from 2000 to 2005. And they looked at a number of statistical analyses to understand what the impact was in different age groups. And they found that some of the previously reported potential risk factors did not independently correlate with more severe disease. And in their study, the only factor that significantly correlated with risk for severe RSV was young age. And that association between prematurity in particular, it was not specific for RSV. So really young age was the only correlation by NVSN, and prematurity did not have a role there, at least at that point. Now we've gone back and asked the NVSN to do another study, and they thought that they had the bandwidth to do it, but they haven't actually been able to go back and pull out data on RSV. So we still don't have updated data from NVSN, but we're hoping to get it sometime in the next year or so. We didn't want to wait for their data to reaffirm our guidance, but we hope that we'll be able to get data from them soon. Now, in addition, the data from NVSN showed that there was no statistically significant difference in RSV hospitalization rates for premature infants born at 30 weeks gestation or greater relative to term infants. So at that time, that really put the big risk in RSV hospitalizations for children born under 30 weeks. So that is 29 weeks and under relative to term infants. And these data were derived from about 130,000 children who were born during the study period, among whom about 2,000 were hospitalized and about 559 had confirmed RSV. And I bring up these specific numbers because we've been criticized for making the recommendation to only limit the use of palivizumab to kids under 29 weeks gestation and under. And it was really, a lot of it was based on these data and other data as well, but these were really important data that really showed us with a large surveillance network, the risk was among children over 29 weeks was the same as the risk to term infants. And people started to kind of split up these numbers and say, well, it was based only on 2,000 children, so it's not really reflective, but it's really based on all of the kids, the 132,000 kids in a pretty robust surveillance sampling. During that period of time, that is going back to the NVSN data, the average seasonal rate of hospitalization from birth to 23 months was 4.6% per 1,000 preterm infants, which was similar to that for term infants at 5.3%. You can see those confidence intervals overlap. But infants born at less than 28 weeks gestation experienced significantly higher RSV hospitalization rates than early preterm. So you can see the rate there is 18.7 per 1,000 as compared to the 5.3 and the 4.6 that we saw for the overall population. Now, the problem, of course, was that the numbers were small. As you see, the numbers of these kids, they represent less than 1% of the birth cohort. So overall, we've had issues with the number of kids that we study, but there was definitely a huge difference in risk for hospitalization in the younger premature babies. Late preterm infants were hospitalized significantly less often than term infants in this particular study. And then another piece of information that came about was looking at other large data sets back in the before 2014. So there was a lot of data, a lot of efforts looking at Medicaid and Medi-Cal claims data, because there was also thought to be some potential for health disparities and maybe looking at lower socioeconomic kids who might depend on Medicaid or other forms of medical assistance. So in an analysis of Tennessee Medicaid data for children less than 3 conducted from 1989 to 1993 in the pre-immunoprophylaxis era, included almost 250,000 child years. And this retrospective cohort analysis was conducted to determine RSV hospitalization rates among infants with different degrees of prematurity and other comorbidities, because obviously comorbidities may have a role in RSV hospitalization risk. Within each age group, premature infants had similar rates of RSV hospitalization regardless of the degree of prematurity. And in particular, the RSV hospitalization rate among preterm infants born at 29 weeks or more was twice the rate of hospitalization among term infants during the first 6 months of birth. Sorry, I didn't include the table. I'll show it to you later. In this analysis, preterm infants with congenital, with chronic lung disease were categorized separately to reduce confounding. And so here's that table. You can see hospitalization rates per 1,000 children. And you can see here is the age stratum or the risk group. These are low risk infants, infants with congenital heart disease, chronic lung disease, and by gestational age or other conditions which are listed here below. And you can see that these were the rates per 1,000 children, and you can see the big risk here for chronic lung disease and even for congenital heart disease and chronic lung disease again here, even in the 6 to less than 12-month-old kids. And those numbers start to flatten a little bit when you get to 12 to 24 months of age, but they're still a little higher. They're still twice as high among those kids with chronic lung disease compared to even the next group here. But you can see here that the incidence rate ratio in particular with compared to low risk infants was particularly high for those with congenital heart disease, and the rates for other conditions were high, but not as high as for those with congenital heart disease. And then there was another study, a historical cohort analysis from Rochester, which reported on hospitalization rates among 1,000 consecutive premature infants born before or at 32 weeks gestation over a 5-year period, the RSV hospitalization rate increased with decrease in gestational age with a breakpoint at 28 weeks. And sorry, I didn't include the table here. I didn't have time to put it in at 28 weeks, but there was definitely a breakpoint at 28 weeks. Or no, it is there. I think it is. Sorry. Among infants born at or before 26 weeks gestational age, the risk was 13.9% versus 4.4% among compared to those born at greater than 30 to 32 weeks. And there was no statistically, let me see if I have the slide. So here's the slide just to show you. So if you look at, unfortunately, this was Karen Hall's study from Rochester. It was a classic older study that was done to really understand what was happening in the pre-palivizumab era. But their breakpoints were a little different than the others. So their breakpoints were at gestational ages of less than 26, 27 to 28, greater than 28 to 30, greater than 30 to 32. And you could see that the risk really, the breakpoint was very clear here at the kids who were greater than 28 to 30 weeks. So clearly kids 28 weeks and below were at highest risk for hospitalization for RSV. And there was no statistically significant difference in hospitalization rates with in between kids 28 to 32 weeks and those with older gestational ages of 30 to 30 weeks. And other data from several large studies indicate that otherwise healthy preterm infants born at or after 28 weeks experienced rates similar to those of full-term infants. And so what we did is, this is a summary now of all of the literature review, and the document that we're putting together is about 60 pages long, so I'm sparing you all of that. But basically, we went back and compared the data from 2000 to 2005, which was used to create, in large part, to create the 2014 recommendations, compared to the little bit of data that we have for 2015 and 2016. Now, we still don't have data for the interval periods from 2017 to currently to 2018. As I said, NVSN has not been able to provide a lot of information there. So we're looking at rates. And now it's important to note that we were not, when we targeted the children that were 29 weeks gestation and younger, we weren't saying that children that were older than that weren't going to be hospitalized. Clearly, anybody who doesn't get palivizumab has a risk for hospitalization, but at what point are you going to give people palivizumab across the board and prevent the biggest group of hospitalizations? So you can see here that when you look at all infants regardless of gestational age and you compare the number of kids, this is the reference group here is all term infants, that is greater than or equal to 37 weeks. Here's the, all of preterm infants overall had a risk of 1.6. Those at greater than 30, this is a risk ratio this is a risk ratio of hospitalizations in the new palivizumab era compared to the old palivizumab era. So that is only providing recommendations for palivizumab for children under 29 weeks. So you see that the risk ratio is a little bit higher, which we expected. We know that you're not going to zero out hospitalizations for RSV in kids, even when they get palivizumab, but especially if you're not recommending it. But the risk ratio was 1.6. It was 1.3 for children greater than or equal to 35 weeks, 1.9 at 30 to 34 weeks compared to the pre-modified palivizumab regimen. And for those 29 weeks gestation and younger was 2.6 higher risk. So these are kids who are still getting palivizumab overall. Now we don't know that these specific children did, but the risk ratio in that young age group who is recommended to get palivizumab still has a higher risk. So we don't know whether this is because the children aren't getting palivizumab or they are and they're breaking through. And this rate is similar to the rate of 29 to 31 week olds who aren't getting palivizumab. So the fact that we're providing recommendations for palivizumab in this group and you're seeing rates that are identical in these two groups did not argue for a change in the recommendations, because even providing it here, you're not seeing a difference in risk ratios in these two groups. And so To summarize then, the vast majority of our hospitalizations for RSV obviously occur among healthy term infants because they make up the vast majority. They make up more than 90%, about 89% of all the infants born in the US. But prematurity is an important risk factor for severe disease, and those born at 29 weeks gestation or less have the highest risk of severe morbidity and hospitalization from RSV, despite the use of palivizumab, as you just saw. Increase in hospitalization rates in preterm infants has been reported by NVSN. I didn't show you that data during the first season after 2014 to 2015, but no data from multiple seasons are yet available. So we're hoping to get those data. We've been asking them for 2 years to provide that, but they don't have the bandwidth to pull that data out and now analyze it. So there are many other reports that are summarized in our technical report. And all of these suggest higher hospitalization rates in preterm infants, but some do not. And they're either limited by 1 season's worth of data, small sample sizes, or inconsistent methodology. But importantly, we have no study has demonstrated an increase in RSV-associated mortality from any of these trials looking at the post 29-week palivizumab recommendations. So immunoprophylaxis remains an option for children at high risk, and those are outlined as with the conditions that you saw: children with congenital heart disease and chronic lung disease, et cetera. But also children under 29 weeks gestation still face the highest risk for hospitalization and are still recommended to get this. And we also know that there are several new options for prevention of serious RSV disease in all infants, and those are under active evaluation. Those include a long-acting monoclone produced by a company that is looking at a new modality to produce this monoclonal antibody, and we just saw a presentation from them a few months ago. And that monoclone looks like it's working pretty well, and there are active trials underway to see if 1 dose of a monoclone given early in the RSV season could protect an infant through the 5-month RSV season. And there are also RSV vaccines that are currently, as you know, under clinical trials, and we don't have any updates yet about the status of those. So we're hoping with the current recommendations and possibly with this long-acting monoclone that there might be other options in the future for RSV prophylaxis in young infants, whether they're preterm or full-term babies. And then I wanted to stop there and talk a little bit. We have a couple minutes left. I just wanted to mention this new syndrome that we're starting to hear about. I want to preface it by saying that we don't know much about it, and actually later this morning, in about an hour and a half, I'm convening the Red Book Committee. We're doing an internal webinar with some of our experts from the UK and the United States around Kawasaki disease to see what's going on now, because we're hearing that there are reports of a new rare condition, and it's started in the report came out of the UK, and I don't know if that's why it's called PIMS, but it's the Pediatric Inflammatory Multisystem Syndrome. We hopefully, and it's similar, it seems to be similar to Kawasaki disease. I don't have any clinical reports to tell you about, except that one of the first reports actually came out of Stanford, and Harashni Matthew and our colleagues here at Stanford Pediatrics were one of the first, I think, if not the first, to report a case here at Stanford. It was one of our first COVID infected children who actually presented with typical Kawasaki's disease and then was tested for COVID because the child had a fever. And actually the child did quite well and went home. But this has now been reported in over 100 cases around the world. It seems like about half of those cases have been reported here in the US, and it's not clear whether the prevalence is higher here or whether because we have such a good registry that we're just picking up more cases. And Jane Burns in Colorado has really done a lot of that work, and she actually will be convening her multi-site, 30-site multi-site Kawasaki group today to talk about this and see how many cases might be reported. And I don't have any clinical information yet for you about that. But it does appear to be associated with COVID. And by that, I mean that some of the children have had COVID infection documented with PCR or antibody or both, but some of them have been in households where there's COVID, but those children themselves have not been either PCR positive or antibody positive. So kind of is a mixed bag. We don't really know if it's related directly to COVID or whether it's been triggered by other factors. As you know, Kawasaki-like disease, we don't really understand the pathogenesis and what might trigger it. It appears to be triggered by many different infections. So what we do know is that some of these kids present with fever and evidence of inflammation. And some of these kids have become quite ill with significant inflammatory responses that have affected a variety of organ systems. And it bears some similarity to Kawasaki syndrome and toxic shock, but appears to be a distinct entity. And as I mentioned last week, there were reports from the UK and other parts of Europe, and the UK people are actually putting together a registry, but did not allow me to share their slides. It was basically just saying that they were going to put a registry together and putting a definition in. So hopefully as soon as they're willing to let us see their definition, I'll share those slides with all of you. And while we have had a number of reports in the US, many children's hospitals have not had reports of this. So it's unclear what this means. But we at AAP will probably be putting out a little alert probably today or Monday, just asking pediatricians to consider doing a COVID test in children who may be appearing to present with either typical or atypical Kawasaki's. And then I just wanted to mention briefly that we are starting, because I would love to get people interested in, we have a partnership with the Chan Zuckerberg Initiative, the BioHub at UCSF and Stanford. We I'm the PI here at Stanford, and George Rutherford at UCSF is the PI at UCSF to do a 2-cohort study to identify incidence of and prevalence of COVID in the San Francisco Bay Area. We launched our study on Wednesday. It involves 2 arms. One is a general population that's going to be representative of all of the 6 Bay Area counties around the Bay Area, and then healthcare workers as well. And these people will be enrolled at baseline in the next month, and then we'll be getting PCR and serology every month through December to try to identify incident disease and also to try to understand the kinetics of antibody development and durability. And then finally, well, 2 more slides. There was just wanted to review, because some stuff has changed over the last few days. Remdesivir, as you probably know, which is, sorry, that's a typo, it's a nucleotide analog. There have been a number of studies that are being done with remdesivir, but it was approved by the FDA under expanded emergency use authorization on May 1st, last Friday, for use in hospitalized adults and children with severe COVID disease based on clinical trials that were done in the US and elsewhere that looked at a 10-day course of IV remdesivir that demonstrated a 30% improvement in clinical outcomes in the remdesivir arm compared to the placebo arm, and a trend towards improved mortality rates, but not statistically significant at that point. And also there was a separate study looking at 5 versus 10 days of remdesivir in severe cases, and it looked like 5 days was as effective as 10. So this is the first drug available, but there, of course, we still need drugs for the outpatient setting. We do have a clinical trials unit here on the Galvez tents. And if you have patients that you think are, these are adult patients only between 18 and 65, we do have a study going on, which I can describe briefly, but you can go to treatcovid@stanford.edu and you'll get information about how to enroll people that they have to have been infected, had a positive PCR within the last 72 hours. So we want to pick people up early. Chloroquine plus azithromycin are believe it or not, there's still a number of randomized controlled trials in the inpatient and outpatient setting. A paper yesterday from Columbia University of over almost 1,500 patients demonstrated, it was an observational trial, not an RCT, but it did not demonstrate any benefit of chloroquine alone, hydroxychloroquine alone. And lopinavir or ritonavir alone has not been shown to be efficacious in a Chinese study, but there are some clinical trials of boosted lopinavir plus or minus hydroxychloroquine and other drugs in other countries that are still going on. Here at Stanford, we have the lambda interferon trial, which is an immunomodulator that doesn't have the side effects of other interferons because lambda interferon targets epithelial cells. It's been shown to be very safe and is going on now. And we're awaiting FDA approval. We have actually a call with the FDA today for favipiravir, which is an RNA polymerase inhibitor, as well as working to get IND approval for Camostat, which is a serine protease inhibitor. It's the TMPRSS2 inhibitor. And these are this is a mechanism by which the virus actually can gain cell entry and begin to infect the cell. So then finally, I just wanted to mention that this is just a summary slide that I got from my colleague, George Rutherford. He did grand rounds up at UCSF and was able to put this nice table together looking at school reopening in different countries. So South Korea is not thinking about opening until next year. Germany, on the other hand, will be opening this week, has opened this week. Japan has had a second wave of disease this year, and it's unclear when they will open schools. China has opened their schools now, so is Australia. And the UK, again, unclear. And I remember the UK also did not do a lot of shelter in place, and they're seeing a fairly a current surge in cases. And there was one study that looked at the risk of a student being infected by a teacher in the first week of reopening at about 0.5%. But I think one of the issues that's been going on around the US is more frequently people are concerned that the children will possibly infect adults. And so before we move to schools, obviously we're going to do a lot of work around social distancing, mixing patterns, and surveillance. So I will stop there and thank you for your attention. And I'm going to stop sharing my slides. So.
All right, thank you, Bonnie. Great presentation as always, lots of information. Why don't we talk about, stay with COVID for a couple questions here, and thank you everyone for your questions. Feel free to type them in. In terms of following on with,
sorry about that.
No, it's all good. Schools reopening. What are your thoughts about preschools reopening? We have a question that pediatricians are getting a lot of calls from parents about preschools, and obviously a critical part of remobilizing the workforce is getting childcare centers going. So what are your thoughts on childcare centers and how?
Yeah, so as you know, the governor has talked about opening day childcare centers, and I do think that we can probably start, we know what seems to be working. For example, even in our healthcare population here at Stanford and elsewhere, we know that appropriate measures, when you take appropriate measures such as distancing, PPE, hand hygiene, those tend to work really well and reduce the risk of transmission. In fact, we have not seen that happen here in the hospital setting. I think some of you have seen something called we're actually trying to build this into our CZI study is a cell phone tracker. So there, and the New York Times had a really cool little graphic. They're really good with their graphics, and they showed that there's quote unquote super spreaders, which I don't like that term because it doesn't really mean anything. It just really means that people are congregating for longer periods. And so if you could distance kids, keep them in individual units. So for example, if you have especially smaller children where you can keep them separate or have them tested and make sure they're asymptomatic, then I think there might be opportunities for opening preschools. And I think that's a goal for this summer. The governor is actually being advised by some of our modelers here at Stanford, as well as others from UC and other places. So I think it is looking like if he goes to the stage 2, which you heard about, or stage 1, right? Stage 2. Stage 2, which is opening low risk areas, there are going to be attempts to open up daycare centers for those populations. So it looks like that can happen.
Great. Okay, looking at the question, staying with schools for one more. How do you think school closures will affect the next season of influenza?
Yeah, so that's why I showed you those slides, because I went back. It took me a while to find those old slides from 10 years ago. I can't believe it's already been 10 years, but I was able to track them down. Maybe that's why my computer crashed right before Grand Round started today.
Yeah, that was super fun. Yeah.
But I went back last night and I found some old slides, and you know, it's interesting that we did see a lull the year after the pandemic, but I don't know whether, so we were talking about this the other day. So on the one hand, it's possible that you could see, you know, because of all the social distancing, maybe there will be a longer time, a longer circulation period. So we might not see an introduction of viruses very rapidly into the population this winter. On the other hand, it could be that if people are all coming back very quickly together, that you might just see a big peak. So you can either see something, or who knows? I can't really predict. I can tell you that when you bring military recruits together, there were studies from the 50s, when you brought military recruits together for the first time, these are 18-year-olds more or less, here in Camp Pendleton, and the one here in, the one in Monterey, I forget the name now. Anyway, you would see rapid surges in meningococcal disease, because you had people who were incubating at home, you were bringing them all together and they were infecting each other. So it's hard to know, but those were people who were circulating in their own communities. And I don't think we've ever had a situation where people were basically sheltering at home for weeks and weeks on end. So it'll be interesting to see. I hope that it's the case that we'll see a lower rate of disease this year, and that by the time next year rolls around, we might have a vaccine or at least some antivirals available, but hard to know.
Okay. We've got a lot of questions. It's 9:02, so if people need to go, obviously we understand. Bonnie, do you have a few minutes to stay with us?
Yes, I do.
Okay, all right. So related to that, what about camps? Summer's coming, overnight camps, sleepaway things for kids. Do you see that as even a remote possibility this summer, or probably
no?
not?
There are camps that are talking about getting back together, and it's very similar to what I said with the daycare centers and the schools. I think it's really going to be a matter of building out camps that can have activities where kids, like archery and swimming, and hiking, you know, things that don't, tennis, I guess, things that don't involve, you know, very close contact, and then spacing out the kids, and whether or not camps feel that they can afford to do that, because, you know, these tend to run on shoestring budgets, but that may be a possibility. I think there's a lot of people who are interested in putting summer programs together for children. I actually just talked last night to the head of the Pac-12, and he's asked me to be on his committee to see if we can get football started in the fall. And I have to say that I'm a big football fan. I know that probably isn't a good thing for, you know, TBI issues, but football is a big draw for the fall. And when I talk to any of my colleagues, these are all medical people, and he said, you know, we might not, people are talking about whether or not to open the schools, the universities in the fall. The first thing 4 out of 5 of them said is, what, no football? So I think if anything, the athletes are a captive audience. So because you can test them, you can, you know, keep them, if you know they're all uninfected, and I don't know whether they'd want to quarantine themselves. That's going to be a tough call, but they're pretty disciplined. If you can keep them active and decontaminate their gymnasiums and all of that, then it's a possibility. So we'll see what happens. But definitely school summer programs are on a list of potentials for the summer.
Bonnie, if anybody can turn the football season into a study, it's you. So that'll be great. So let's go from kind of population level down to some more specific. A couple questions about the PIMS, Kawasaki-like illness. What are the ages of the children who are having that? And
well, the patient, so some of the patients that I know about have been as young as 4 months of age. And I think there have been older children, you know, in their, you know, 6, 8-year-old. I think maybe there were even older kids, teenagers. So I don't really have any of the details. Unfortunately, I'll find out more in about an hour. I won't know much.
Right.
I don't know much
It's
now.
rapidly changing.
Yeah.
How about treatment recommendations for those kids?
Yeah, I don't know. I think people are doing the same thing that they're doing for Kawasaki at this point. And one person asked me about IL-6 inhibitors. But I don't have any experience with IL-6 inhibitors unless somebody in the audience does. And that's just a general recommendation because they say that that may be effective in Kawasaki, but I don't know that literature at all. But
Okay.
I'm not going to recommend it because I don't know anything about it. So
Yeah. Okay. Okay. Last kind of COVID related, person's asking, I've heard remdesivir will be distributed only to a few select hospitals around the country. Is that true? And how will you get it if you're hospitalized in a different location?
it's a travesty. I will just say it. It's terrible. It was developed at Gilead right up the road here. All of the doses have been sequestered by the federal government. It's apparently being distributed by HHS, and there's a really good article in the New York Times about this. Nobody knows how it's been decided. Nobody. And HHS hasn't said how they're giving it out. It makes no sense. Some hospitals with many, many cases are not getting it. Some hospitals with small numbers of cases are getting it. Some hospitals with large cases are getting it as well, but it seems extremely random. And nobody's putting out national data. There's zero transparency about how it's being given out. So it's unfortunate. I will say, and I think I'm allowed to say that there are going to be new formulations of remdesivir, and there's a new trial that may be starting here at Stanford. It may be an outpatient trial. I'm not sure yet.
Okay.
So
interesting. In terms of trials, a question, how can we participate in the Stanford UCSF CZI research study?
Yeah, so unfortunately that study is a pre-selected group of people. They had to have come in to have a previously a negative, come in for testing, PCR testing, have a negative test because we want to look at incident disease. And then what we did is we took that list of people anonymously and then just did a random pick based on the demographics of the population. So we're doing it by zip code, by county, because it really needs to be representative of the whole county. And for healthcare workers, you can't be a healthcare worker. So basically anybody on the call probably can't do it. But if you're a healthcare worker, you might, if you've had a PCR test in the past, whatever, since this started, you feel free to go to the, let's see, do we even have a website yet? We don't have a website. We've just building up our website, but you can email me. I may not respond, but somebody in my team may respond because we may be asking for healthcare workers. That's going to be a little more intensive. We're going to ask people to, well, it's actually not more intensive. We want to collect antibodies as well, blood for antibodies testing. So the healthcare worker study might be more likely for people who think they've had had a negative PCR test in the last few months.
Got it. Okay. Let's switch to vaccines here. Number of my patients are requesting the BCG vaccine. I saw reports of some studies looking into this old vaccine and its protective effects. Comment? Yeah,
no data. So we don't recommend BCG. So there are studies around BCG. There's also actually a study that I didn't understand very well around polio vaccine too. So the idea that polio and BCG somehow stimulate immune responses that could prevent infection or serious symptoms. I have not seen any data to support that. There are studies ongoing in sub-Saharan Africa and other places looking at BCG as a booster to prevent TB, to prevent active disease for TB in adolescents. And so but that's a specific randomized clinical trial that's ongoing now. But no, I wouldn't give BCG at this point.
So leaving the land of COVID here, Steve Alexander's asking if you could please review recommendations for flu vaccination in immunocompromised kids.
Well, I think I'll refer you to the CDC website, but there's a number of there's so many different conditions for which we do and we don't recommend it. I think he's probably referring to kids with chronic kidney disease.
Yeah.
So I think whatever the previous recommendations are, we did not change them.
Okay.
So, and those go back and forth, but at this point, and I don't know if Grace is on the call, but I can't remember what we said about chronic kidney disease. I know we spent a lot of time talking about it, but I can't remember. Sorry about that, Steve.
Okay.
We'll get to those recommendations.
Okay, phone a friend, Grace, if you're out there, type into the chat box. And then when the CDC reports deaths from influenza, do they share percentages of those deaths for people who are immunized versus unimmunized?
Yeah, right. So the vast majority of those people who die, about 80% or more, are not vaccinated. Now, and then just so you know, when you calculate vaccine effectiveness basically is a population-based way of looking at the way a vaccine works in the real world. So what you do is you look at all people who come in with flu, and then you figure out how many of those were vaccinated versus how many were not vaccinated. So that's how you calculate the risk of hospitalization. They don't do the same for mortality. But basically, if you look overall at the data in a different way, so the other way to look at it is how many of the actual cases were vaccinated and unvaccinated. And they tend to bury that somewhere in their reports. They don't always have that information, but in general, it's about 80% unvaccinated.
Okay. And we will end with a question about Mother's Day, appropriate. After sheltering or wearing PPE on the street and in stores for the last 8 weeks, how safe do you think it is for families to get together and meet on Mother's Day?
Yeah, that's a tough question. I'm just gonna admit it. My son is living in Austin. He's not gonna come out, and he's a son anyway, so I'm not sure he would have. He said he would have liked to have come out, but he has a cat and he can't leave the cat at home, etc. But my daughter and her husband have been sheltering at home for a month, and they were afraid. They said, "I don't want to infect you because then you won't be able to do all your work." So, but they're coming for the weekend, but they haven't been around anybody for over a month. So hopefully I'll be healthy next week. But I think if people are sheltering in place, I know that some of the faculty have been seeing their kids who have been really sheltered. That is not being out in the public. So, I know you're not, we'll see. So I can't make an official recommendation there. We have to follow the Santa Clara County guidelines.
We'll take the party line on that. And for those of us who are living with our kids, we'll see if we even feel like celebrating it.
That's right. I was thinking the other extreme is when you're with the kids all the time, how do I get a vacation from the kids on Mother's Day? So.
Exactly. Anyway, Bonnie, thank you so much. We know.
Yeah, thanks everybody, and good luck, and stay safe, and have a good weekend.
Thank you so much.
Happy Mother's Day to everybody out there, all the moms.
Yes, likewise. And we'll see you all next week for the Redeem DeCarlo lecture.
All right. Take care. Bye-bye.